Thanks very much, Ravi, and thank you to Carlos. Many thanks for the invitation. It's a great pleasure for me to join you this evening. So I've been asked to talk about clinical examination of the elbow, and what I'm going to talk to you about is my approach. You will all have things that work for you, and there are many ways to crack the nut, as it were. So this is just the things that I find helpful, a few key points to highlight, and a few catches that will sort of common mistakes that I see people making. These are my disclosures. None of these are relevant to the subject of this evening's talk. Before talking about elbow examination, we need to consider what is the purpose of the elbow. The elbow is the link between the shoulder and the hand and the wrist, and the purpose is to help us to position the hand in space. It's the elbow on this robot here that stops the passenger being scraped along the floor and up the walls of the warehouse. And of course, without a functioning shoulder and a functioning hand and wrist, an elbow in itself is not particularly useful. But equally, there's no point in having a useful hand if your elbow isn't working and you can't position it to be able to manipulate the environment around you. We also need to bear in mind that the elbow cannot be considered in isolation. The elbow is part of a functional unit with the forearm that allows us to both flex and extend and pronate and supinate. And you have one-to-one movement between the distal radial ulnar joint and the proximal radial ulnar joint. So any movement that occurs through the radial head is going to affect the distal radial ulnar joint as well, and vice versa. So if you get stiffness of the forearm, you need to consider the whole of the forearm articulation to determine the cause of that stiffness and to make the diagnosis. So how do we make the diagnosis? So many of you, I'm sure, will be familiar with the concept of Bayesian diagnostics. We're all Bayesians at heart. It's just inherent in the way that we tend to think. And according to Bayesian probabilities, we consider our initial probability, and then we collect data which we use to update that initial probability to come up with a new probability of the possible diagnosis. So maybe when we get a clinic letter from our GP colleagues, we might get a letter referring a 45-year-old male with lateral elbow pain, and instantly we're thinking they've probably got lateral epicondylosis. We take a history from the patient. It's of insidious onset lateral elbow pain with no clear history of trauma, and therefore our new probability isn't really changed. It fits with what we thought beforehand. But then we examine the elbow, and they don't have tenderness focally over the lateral epicondyle, although the Mills and Morsley's tests are positive. But that causes us maybe to just revise or downgrade our probability that this is tennis elbow or lateral epicondylosis, and maybe we're thinking about one of the alternative diagnoses. But we're concerned enough that we think we need to get further investigations with ultrasound or MRI scan, and that comes back with strong evidence of lateral epicondylosis and no alternate diagnosis suggested from that investigation, and that therefore increases our probability of the diagnosis of tennis elbow. And that is a natural process. It's a process that is going on all the time in our heads when we're using these different measures to achieve a diagnosis. And with regard to clinical examination, we use the time and tested Apley approach of look, feel, move. But in my hands, for the elbow, I take a slightly, change the order of these slightly. I start with the looking, but then we use movement as a good screening tool for diagnosis. We then palpate and then apply various stress tests. And I think it's helpful to think about diagnoses in terms of lateral causes of pathology, medial causes, anterior causes and posterior causes, and we're going to go through that in this examination approach. Of course, there are pathologies that will affect the whole of the elbow, medially, laterally, and we need to consider those. And of course, using our Bayesian diagnostic approach, we're also going to be taking other factors into consideration in our examination and in our diagnostic algorithm, such as the age of the patient and their sex. So we start by looking at the elbow and the arm. We need to expose from the shoulder down to the fingertips. We look at the carrying angle. We compare that to from one side to the other. Of course, the elbow, if the elbow is in a fixed flexion posture, then the carrying angle can't be relied upon because external rotation of the humerus will alter that. We look at the lateral side of the elbow for any scars. We look for swelling in the soft spot area, which would indicate an effusion. And then we come to the medial side and make sure that you do fully externally rotate the arm to look on the medial side, because bruises, scars from previous ulnar nerve surgery can be hidden in that area against the side of the body and may be missed. It can be helpful during this inspection to flex the elbow just to see if there's any signs of instability of the ulnar nerve. We can look at the front of the elbow, look at the antecubital fossa, which is bounded laterally by brachioradialis, medially by the common flexor origin, and particularly at the proximal end pronator teres, and then by the line joining the medial and lateral epicondyles. And swelling in that area may suggest a distal biceps bursopathy. And then finally, we would look at the back of the elbow and looking for any swelling. We want to look at the height of the biceps from the antecubital fossa to look for any retraction. We're looking for any bursal swelling on the back of the elbow, any nodules or swelling which might indicate a diagnosis of gout or rheumatoid arthritis. We then want to do a screening movement of the elbow, and it's helpful to stand the patient up facing you and ask them to put their arms out to the side, and then from that position to flex the elbows. And when you're asking them to flex the elbows, you're looking at the space between the biceps and the forearm. It's much easier for your brain to interpret a widening of that space than the actual angle between the forearm and the upper arm. And we always use a goniometer in the clinic. Forearm pronosupination should always be assessed with the elbow tucked in by your side, with the forearm flexed, or the elbow flexed to 90. And we're not looking so much at where the palm is. A lot of people will ask the patient to grip a pen or a ruler and then look at how the movement occurs in the hand. But of course, the wrist can account for 10 degrees of pronosupination, and will often, the patient will be compensating in the wrist. So we're actually looking at the radial styloid and the ulnar styloid and the position of those when examining forearm pronosupination. We'll then come to specific considerations and specific diagnoses. With lateral elbow pain, there are common things: lateral epicondylosis, radiocapitellar osteoarthritis, posterolateral rotatory instability, Plica syndrome, and then the very rare radial tunnel syndrome, which is probably overdiagnosed. And of course, for all of these, lateral, medial, anterior and posterior, there are always traumatic causes that we need to consider. So again, when we're palpating, it's helpful to start proximally on the lateral ridge, to come down to the lateral epicondyle and palpate the origin of the ECRB. If you move about a ½ centimeter distal to that, you'll be over the origin of the lateral ligament complex, and a centimeter distal to that down the forearm will be the radial head. And then we can move dorsal to that to palpate the distal insertion of the lateral ulnar collateral ligament. So we would expect with somebody with lateral epicondylosis to have focal tenderness over the lateral epicondyle. They may have some swelling. They shouldn't have stiffness on our screening examination. For special tests, there are a number of tests that are described. You can use Cousins' test, which is resisted extension of the wrist with the elbow at 90 degrees, and to see if this reproduces pain over, under your thumb over the lateral epicondyle. Or we can use Mills' test, which is to flex the wrist and then slowly extend the elbow, again with your thumb over the lateral epicondyle. You say, if they say they've got pain, where is the pain? Is it under my thumb? Don't rapidly extend the elbow, because the patient will pretty rapidly hit the ceiling, because it can be a very painful investigate or test to undertake. My actual preference is to use the Maudsley's test, which is with the elbow in full extension to apply pressure to the middle finger, which is while the patient tries to maintain that in extension, as I find that a little bit more specific for lateral epicondylosis. The Mills and Cousins tests can be positive with other pathologies. And particular pathologies that you might be considering, especially in the older patient, is radiocapitellar osteoarthritis. But of course, remember that in manual workers, radiocapitellar OA will typically present around the age of 50 years, and so is very much in that spectrum of tendinopathies and needs to be considered in the differential diagnosis. The grip and grind test is a helpful test to assess for radiocapitellar osteoarthritis, because you get co-contraction of the common flexor and extensor origins, and that will often reproduce pain. But again, there can be positive, you can get a positive test in tennis elbow. We then want to consider posterolateral rotatory instability, if there's a history of trauma, if the patient's reporting locking symptoms in the elbow, or more of a sharp stabbing pain in the lateral aspect of the elbow. We always start by examining valgus stability before fully internally rotating the humerus, so that we take humeral rotation out of the picture. And with the elbow flexed at about 30 degrees, we then want to apply a varus force to the elbow. The reason to have the elbow slightly flexed is to take the olecranon out of the olecranon fossa, and we can determine if there's any lateral instability, comparing that to the contralateral elbow, of course, and bearing in mind that the Byton score of the patient, the hypermobility score of the patient, which may account for more significant movements. I think one of the most useful tests for posterolateral instability is the posterior draw test. So the elbow, you have the patient seated. This is obviously an asleep patient on the operating table, but you can have the patient seated with the arm across their lap, and you grip the radial head anteriorly and posteriorly, and just apply a dorsal force to the radial head and see whether it translates dorsally. You can get the patient very relaxed in that way, and you'll often detect that instability. Just bear in mind that that can be a positive test if they've, with an intact lateral ligament, if they've torn the posterolateral ligament, and that can be a useful differential diagnosis. We don't use the pivot shift test in the awake patient, but in the asleep patient, this is how you do it. With the arm overhead, you fully supinate, you apply a valgus force and slowly extend, and then flex the elbow radial head drops back into joint. But in the awake patient, they won't allow you to dislocate the elbow. In this position, however, you can do the posterior draw test. So lying them down and bring the arm above the head is another good way to do that posterior draw. Other provocative tests for PLRI include the push-up test, where you get them to push up from a chair. You need a chair with arms like this. and you start off in pronation, where they should be more stable and they should be able to push themselves up out of the chair. And then you ask them to rotate the forearms so they're in supination, and then again to repeat that. The problem with this test is, as you can see, if you have a chair which is quite narrow like this, it's actually quite difficult. So I prefer the tabletop test, where you get them to do a press up in pronation initially on the edge of a desk or a table, and then in supination, and they should struggle to do it in supination if they have a PLRI. You can then apply a force onto the back of the radial head, and that should then enable them to do the press up, because you're keeping the radial head in joint, and that can be a useful test. Other causes of lateral elbow pain include Plica syndrome, and a plica can be anterior or posterior more commonly, or circumferential. Difficult for me to demonstrate in a video what's going on there, but from this arthroscopic video, you can see this anterior plica flicking over the radial head, and you would be able to palpate that through flexion extension with your thumb over the radiocapitellar joint. Sean O'Driscoll's also described the Plica compression test. So this is where you put the forearm in pronation, you apply a valgus force with your finger over the posterior radiocapitellar joint, and you slowly extend the elbow. And if they go, ow, yeah, that's my pain, then that would be strongly suggestive of a posterolateral plica. And then I mentioned radial tunnel syndrome. Again, I think this is really overdiagnosed. Most lateral forearm pain probably comes from the lateral epicondyle or the radiocapitellar joint. And it's very much a diagnosis of exclusion. But if there's tenderness, no tenderness over the lateral epicondyle, but there is tenderness 4 centimeters distally and a bit more anteriorly over the radial tunnel, then they may have radial tunnel syndrome, assuming all other investigations are normal and you've excluded all other pathology. A diagnostic ultrasound-guided injection can be helpful if you are considering that diagnosis. So then we start to think about, move on to the medial side of the elbow and what can cause symptoms on this side. Of course, we consider medial epicondylosis as a common cause. Ulnar nerve pain with or without numbness or tingling in the hand, or weakness. In the early stages, they may just present with pain around the medial side of the elbow. A snapping triceps, which is often missed. People will think that it's the ulnar nerve that's snapping, but the ulnar nerve isn't under tension and therefore can't snap. And then medial ligament injuries, and we should look specifically for bruising adjacent to the medial epicondyle to make that diagnosis. So one of the most common mistakes I see is that when people are assessing medial epicondylosis, they assess wrist flexion. But most medial epicondylosis isn't affecting the long flexors, but is affecting pronated teres. So you have to assess resisted supination by asking the patient to maintain a pronated position with the elbow extended, and then as you try and supinate, they maintain that position, and that is more likely to reproduce their symptoms. So most medial epicondylosis involves pronated teres, and it's forearm rotation that reproduces the symptoms. The ulnar nerve needs to be assessed through a range of movement. So we palpate the ulnar nerve, we make sure that it is sitting in the retrocondylar groove, that it's not tender in that location. We then flex the elbow to see whether it subluxates in flexion, and then we can of course do a Tinel sign. And a positive Tinel sign is pain or tingling experience in the ulnar side of the hand when we percuss over the ulnar nerve. We should move from proximal to distal down the nerve to see if that reproduces the symptoms. As I said before, snapping triceps is often misdiagnosed as an unstable ulnar nerve. And the reason for that is that the snapping triceps will cause, in most cases, ulnar nerve symptoms, but the nerve is an innocent bystander. So as we come into flexion, the nerve goes, there's the nerve, and there's the tendon. So what we're looking for is that double subluxation on the medial side of the elbow. And when you do an MRI scan, what you'll see is that there is an accessory band within the medial border of triceps. It's actually present in about 75% of the population, but is only symptomatic in a small proportion. At the time of operation, you can see the ulnar nerve moves, and then the band move, the tendon within the medial head of triceps moves, and I can dissect out that tendon, which is always surrounded by muscle, so it's easily missed, and there you can see it subluxating. And the treatment, of course, is to excise that and to transpose the ulnar nerve. But the important thing is to be aware of the diagnosis. If it's snapping, it's a snapping triceps in most cases. And you can, Spinner's test is helpful to support the diagnosis. So here I'm asking the patient to provide some resistance against my hand as we go from flexion, from extension into flexion. And what you'll hear is an audible snap as the elbow, as the snapping triceps flicks. I'll just repeat that. So it's not always audible, but it will reproduce the symptoms, and so we need to consider that. Medial ligament injuries can be acute. They can be acute on chronic, or they can be chronic injuries. And we'll assess the medial ligament by fully externally rotating the humerus so that we take humeral rotation out of the picture. Again, flexing the elbow to about 30 degrees. And it helps to lock the hand in on your hip with your forearm, and then you can apply a very controlled force laterally on the elbow. What I'm looking at is the flexor pronator mass to look for fasciculation. And it helps often to put your fingers either side of the joint, and you can see if there's a gap opening between your fingers, indicating valgus instability of the elbow. The milking maneuver, you can get the patient to do that, and this is a painful provocative test for more chronic instabilities. So you ask them to pull on their thumb. The problem is that it can be difficult for the patient to get into this position, and by the time they've worked out what you're trying to demonstrate, they've lost interest. So I actually do it myself. I pull on their thumb at about 70 degrees of flexion, and I repeat it at 120 degrees. So 70 degrees for the anterior band, 120 degrees for the posterior band of the medial collateral ligament, and it'll reproduce their pain in many situations. And then the moving valgus stress test is described, but is not something I use. You have to wrap the elbow, and that produces the pain with force. But it's not very fair to the patient. It's quite painful, and I don't think it gives us any more information than the milking. And then we need to look at anterior. And causes of anterior elbow pain include median nerve symptoms, trapeziodundal lacertus fibrosis, but most commonly it's pathology of the distal biceps, tendon sheath or bursa, and we can palpate over the tuberosity 4 centimeters distal to the flexor crease, and that may reduce pain symptoms if there's a bursitis or a distal biceps tendinopathy. So we need to consider that. We need to also consider internal coronoid impingement. So that's we often see in boxers or rugby players or people with osteoarthritis, and forced flexion of the elbow will reproduce those pain symptoms. I'm sure we're all familiar with the Biceps O'Driscoll's hook test. So importantly, the shoulder is abducted, the forearm flexed to 90 degrees with a forearm in supination. And it's easiest just to ask the patient to bring their hand up in front of their face and look at their palm. And then we bring our finger in from the lateral side, and you should be able to hang your coat on your distal biceps tendon in that position. It's important that we do it in that position, because if you do it in this position but by your side, you can actually hook brachialis tendon, which will also be tense, whereas brachialis will be relaxed in that position and you won't inadvertently hook that. So it's a really good and useful test, but it's important to be aware that in 80% of complete ruptures, as in the illustration on the bottom right-hand corner here, this is a complete rupture, but with an apparent intact tendon on O'Driscoll's hook test. And that's because the tendon doesn't always fully retract. If lacertus remains intact, then you will still be able to hook something. It might feel different to the contralateral side, so it's always useful to compare contralaterally, but be aware that the O'Driscoll's hook test may miss some tears. And so I always combine it with a biceps squeeze test, which is a bit like the Simmons test for the Achilles tendon ruptures. Rest the arm on the forearm on the lap, where the hand takes a slightly pronated position, and then we just squeeze the biceps, and you should get passive supination. And what that tells us is there is continuity between the biceps muscle and the tuberosity. They may have a partial tear, which we wouldn't pick up with this test, but if there's a complete rupture, then that's helpful. So for picking up partial tears or tendinopathies, we can either do a resisted O'Driscoll's hook test, where we do the hook test, but apply a force into the palm as we hook the tendon. And if that's painful, then that might indicate a partial tear or tendinopathy. But Roger van Riet and Peter Kekebeck from Belgium have described the Antwerp provocation test. So they should have less pain in supination with resisted elbow flexion and more pain with a pronated forearm, because we're squashing the torn tendon against the tuberosity in pronation because of the tendon anatomy, and that may reproduce their painful symptoms. So that's a useful test. And then lastly, we think about posterior causes of pain. Sometimes these are obvious, like an olecranon bursitis. There can be pathology of the triceps tendon and posterior olecranon impingement. So just as we can get impingement from the coronoid, we can do forced extension of the elbow to see if there's pain posteriorly coming from the olecranon impinging in the olecranon fossa. Some posterior elbow swellings are obvious, but some can be challenging. This was in fact an olecranon bursitis, but you might have in your differential diagnosis gout or even tumor when seeing a lesion of that size. The triceps is best assessed overhead, and we want to use the MRC scale and assess triceps power against gravity, and always palpating the triceps tendon. But you must be aware that in most triceps ruptures, they tear the long and the lateral head, and the medial head is intact, and very often they will be able to extend against gravity. And we can do the triceps squeeze test just like the biceps squeeze test, but again, that may be falsely negative. So be aware of the way that the triceps fails. One of the useful examination findings is just to get them to fully lock out their elbow and extension. And what you'll see is that the triceps bellies are sitting at different heights. The long and the lateral heads will be sitting much more proximally compared to the contralateral side, and that will therefore give you the diagnosis. And of course, MRI scan and X-rays can be helpful. So that's a really brief run through some key points of elbow examination. It's not exhaustive, and there are many other special tests that we could go through. And if you've got further questions, I'm happy to answer that. But you need to have a system. It doesn't matter what your system is, but have a system. Know your anatomy well. Every good examination is based on a thorough understanding of the anatomy. And of course, practice. The more you examine the elbow, the better you'll get at it, the better you'll get at making the diagnosis. Thank you very much indeed.